sir. Could you join, sir?
Good evening and welcome everyone. I, Dr. 𝗜𝗡𝗟𝗟𝗢, on behalf of Voice of Healthcare, welcomes all the speakers
Hello.
and the viewers who have joined in for this discussion today on World Cancer Day on the topic Closing the Care Gap, Where India Stands, organized by Voice of Healthcare and supported by Cipla. This discussion aims to bring together experts and stakeholders to discuss ways to close the gap and improve access to quality cancer care for all. I would like to commence this session by introducing the moderator for this session. I welcome Dr. Neha Sadotra, Program Chairperson, MBA Healthcare Management, School of Business Management, NMIMS. Welcome, Dr. Neha.
Thank you, Dr. Radhika. Good
Over
evening,
to you, ma'am.
good evening, everyone. Welcome to all joining us online, and thank you so much for investing your time with us on a Saturday evening. The campaign theme, Close the Care Gap, recognizes the power of knowledge and it challenges the assumptions that we people, the normal people, have made about cancer. Now, this second year of the 3 year campaign raises awareness about uniting our voices and taking action. As this 3 year campaign continues, we will join with like minded people because we know that we are stronger when we are united. I would start off with a really quick introduction for our amazing panel here. So, we have today with us Dr. Jyoti Bajpai, medical oncologist and professor of medical oncology, Tata Memorial Hospital, Mumbai. Dr. Harit Chaturvedi, Chairman, Max Institute of Cancer Care, Max Healthcare. We have Dr. Boman Dhabhar, Senior Consultant Medical Oncologist, BND Oncocare Center, Fortis and Messina Hospital, Mumbai. We have Dr. Niti Raizada, Senior Director, Medical Oncology and Hemato-Oncology, Fortis Hospital, Bangalore. We have Dr. Prakash Fernandes with us. He's heading the Palliative Care Partnerships at Cipla Foundation. And we have Ms. Urvashi Prasad, Director, Office of Vice Chairman, Niti Ayog. A warm welcome to all of you. As we all know, the theme of this panel discussion is closing the cancer care gap. Our objective with our time together today is to build awareness about cancer and understand what does India's performance report card look like when it comes to closing cancer care gap. So this is going to be a sort of little appetizer. We are not going to get into everything in the tremendous amount of depth. So for our audience here, please feel free to follow with questions in the comments. So let's get started and understand cancer better with our experts. I'll kick off the conversation asking questions that brings out some of the insights on the prevalence of different types of cancer in our country, India. And my first question is to you, Dr. Jyoti Bajpai. Dr. Jyoti, please throw some light on the most common cancers in our country, India.
So thank you very much, Dr. Neha, and indeed a great pleasure and privilege to join this stage with all of you. And today's World Cancer Day, so I would rather, I'm really delighted that we can share some knowledge and it can serve as a small step in closing the gap, as you rightly mentioned. So, since you asked about the common cancers, at present, if I'll talk about the women cancers, then breast is the predominant type, followed by gynecological cancers, predominantly cervix. So previously, as we are aware that cervical cancer used to be a dominant cancer in India for a longer time, but with the screening facilities, with the more awareness, gradually this is going down. However, with the urban lifestyle and many other factors which can largely be modifiable also, the breast cancer is gradually creeping in, and now it is as the predominant cause. So not only world over, but in India also, especially in all the urban registries, breast cancer is the predominant type, which is my area of interest as well. When we talk about man cancer, so it is lung, as we know, it's the predominant, and again very largely associated with smoking. Then head and neck is one major cancer in India. Then certain parts of country there are gallbladder cancers, which is in general rare, but in certain pockets this is also seen commonly. But lung, head and neck, prostate, these are the major cancers.
Thank you, doctor. Thank you very much. My next question is to Dr. Harit Chaturvedi. Doctor, what are the common cancers in females? If you could give us some detail on that, and Another question for you is, if women are affected with these cancers, can it also affect their daughters or their granddaughters in a way? Dr. Harit? I guess Dr. Harit is not there. So, okay. So I'll ask another question to, yeah, I guess he will join shortly. Okay. So I'll ask a question to Dr. Niti Raizada. Dr. Niti, how common do you think is pediatric cancer in India? And which are the most prevalent pediatric cancers in India?
Again, I'll start by saying thanks so much, Neha, for inviting me today. It's a nice day to discuss this about cancers because it's World Cancer Day, and we all need to close this gap or probably create more awareness about all sorts of cancer. So, pediatric cancer as a subset is a rare cancer. Less than 5% of all cancers are pediatric cancers. Based on the age cutoff, whether it's 15, less than 15, or less than 18, almost 1.6 to 4.8% of all cancers are pediatric cancer. Now, what we have to understand is we also have a system of underreporting in our country. The number of pediatric cancer in the West is quite high, but we have lesser number of cases. Pediatric cancers are also a set of cancer which have very good results. So 85% survival rate, 85% long-term response rates are seen. But that's not the statistics we have in our country. Our country will have probably later presentations and probably more advanced pediatric cancers, and therefore the survival is less. Now, you asked me what are the common pediatric cancers. So, common pediatric cancers are leukemias and lymphoma. And the most common pediatric cancer is acute lymphoblastic leukemia, which is a blood cancer. Then, other type of solid cancers are neuroblastoma, they are nephroblastomas, and sometimes even bone cancers and brain tumors.
Thank you, Dr. Niti. Now let's talk about the advances in the diagnosis of cancer. Dr. Boman, my next question is for you. How can early diagnosis be made possible in India? And I would like you to talk about the advancements that we have made in the diagnosis of cancer. Dr. Bowman, are you there? I guess there's some issue with Dr. Bowman's camera. Dr. Bowman, are you there? Okay, I'll move
Hi,
on to, yeah.
yeah, can you hear me?
Yes, doctor.
So, for early diagnosis, the key to early diagnosis is taking part in screening. And what everybody should know is screening is for normal individuals, those who are asymptomatic for that disease or for cancer. So, that will be the main thing that we should stress upon. People feel we don't have symptoms, why we should go for screening? But it is a screening, especially in few malignancies, it has been found to improve the survival, to catch the disease early, especially in breast cancer, I would say in lung cancer, in cervical cancer, of course, in colorectal cancers. They are they are the main organs or main cancers where screening has made a dent to catch this disease early, and we can cure these people if we catch this disease early. And of course, there are now, if you have to go a little bit more details in screening, there are high risk groups like people who are BRCA positive. They should be screened more often and screened in a different manner. So, high risk group, family history of malignancy. So, those are the people where screening still takes an important part, like chronic smokers for lung cancer, what we call as low volume CT scans or low dose CT scans can catch the disease early. It has decreased the mortality by more than 10% if you catch these people. Of course, stop smoking is the most important sign, is the most important thing for them. So screening is one. And for early diagnosis, we have a lot of now newer things. We have PET CT scan, we have a lot of different type of scopies that are there by which we can catch the disease early.
Thank you, doctor. Dr. Harit has joined us, so I'll ask my question to Dr. Harit. Doctor, what are the common cancers in females? And if women are affected, can it also affect their daughters, their granddaughters?
So basically asking what are the common cancers in women. Yeah, okay, fine. So thank you, Neha, for having me, and sorry for being a bit late. I was caught in another World Cancer Day program. So good that we are all doing this, because awareness is the most important tool which helps in bringing down the delayed diagnosis, and awareness can also help in preventing a lot of cancer. So to talk about this, I would say that breast cancer is the growing or the number one cancer today amongst women. Cervical cancer is also up there as the second most common thing, but breast cancer has taken over that. And as we know, today breast cancer is quite treatable in a way that the results are much better. It is a cancer which can be screened also, it can be picked up early. So we need to really spread the awareness very well, and help get an early diagnosis and detection of breast cancer. Now, as far as the effect in families and genetic predisposition is concerned, that is something which is only there in 5% of women. Nevertheless, it has to be assessed. So every high risk person, or when there's more than one first relative who has got breast cancer, we need to have a genetic counseling and then subsequently go for screening or testing for that. Triple negative breast cancer or bilateral breast cancer, or those with a history of male breast cancer. So there are certain criteria which have to be used where one can manage to go for genetic counseling and screening for mutations. So that is possible and should be used as much as we can. And as far as the cervical cancer is concerned, we know that it was used to be one of the commonest cancers as far as women are concerned in India. But with growing health awareness, education, hygiene, the less incidence of the multiparity has gone down. So these things have, as the economic status and education has gone up, the cervical cancer has gone down, especially in the big cities. And also that the vaccination is another tool which is helping in playing a role for the HPV vaccination. But I think the better or more important tools have been the education level, the economic status. These things have helped in improving bring down the incidence of cervical cancer. So, yeah.
Yeah. Doctor, is there any effect on, I mean, as I asked the second question, that if a woman is having cancer, so would it affect their daughters, or, I mean, their daughter or their granddaughters also? I mean, what are the chances? What are the
So
probabilities?
I feel that we should not think that cancer is a genetic disease. It is. There are some incidents, that is 5 to 7% of cancer is genetic in nature, where the gene line mutations, germ line mutations play a role in transmitting the disease. But it's not that every breast cancer woman will pass it on to the daughters and granddaughters. That is a wrong notion. What we need to know, there's a subset of patients which, once proven, only then we should educate them, inform them, and as I mentioned, that genetic counseling is very important. That should be integrated. Only then these people should be taken up for testing, because it should not create apprehension and psychological problems and social issues related with that. So a lot of times women, we educate and we want them to have screening. They say that, no, I don't want to have the test. Once they're informed, it is their choice, matter of choice. So that is different. As far as passing down is concerned, I think we should keep this conversation in a manner that only a small subset of patients have these germline mutations and will pass it on to the next generation probably.
All right. Thank you, Doctor. My next question is for Ms. Urvashi Prasad. Um, Ms. Urvashi, are there any policy decisions being taken or planned in regard to early detection of cancer? And how the national programs addressing the burden of cancer, how they're actually addressing the burden of cancer in our country?
Yeah, thank you for having me here. And to address your question, so yes, there are different programs which focus on both prevention as well as early detection. But I think the most important, one of the most important initiatives that the government is focused on now are the health and wellness centers, which are being set up under Ayushman Bharat. We have around 1.5 lakh such centers which have now been established across the country. But these, are going to be operationalized fully in the months to come. And the important shift, there is, if you see India's primary healthcare, historically it has mostly been focused on reproductive, maternal, child health, and of course we still need those issues. They are still very important, but we haven't really focused on non-communicable diseases. We haven't really focused on things like cancer screening. We haven't focused on prevention, well-being, promoting healthy lifestyles. So we've had a very cure focused health system. uh, you know uh, in the past we've always had a health system which is focused exclusively on doctors and specialists. And of course you need doctors and specialists, there's no denying that. But you also need a public health approach, especially when it comes to prevention, when it comes to screening, when it comes to early detection. A public health approach is of the essence. So we are trying to operationalize, these health and wellness centers to undertake comprehensive screening for cancer, at least the major cancers that we see, oral cancers, breast cancer, cervical cancer, and so on. And also we are trying to equip our health workforce, and again by that I mean not just doctors and specialists, but also other cadres of health professionals, to be able to at least pick up some of the early potential signs and symptoms of cancer, to be able to create awareness about diet, about healthy lifestyles, about the importance of exercise. Because like I said, we cannot have doctors and specialists everywhere, and especially in a country like ours, in the rural and remote areas, we have an acute shortage, of doctors, of specialists. So of course we need to increase their numbers, but we also need to engage our other health cadres, especially our public health cadres, to create awareness, and to also educate people about early signs, symptoms, so that we can promote early detection. Because as we've been discussing, that in India major challenge is that a lot of the cancers are detected at very advanced stages, when it's not only more difficult to treat them, but it's also more expensive. It also becomes a big financial burden for many families in the country. So we need to really focus on that promotion of well-being, prevention, as well as screening and early detection. So I think that is one set of efforts that we are trying to undertake. The other is of course on the treatment end of the spectrum. Because somebody who does get cancer, like I said, there's a huge financial burden. There's an access gap in our country. You can come to a larger metro and you'll find all the facilities, but if you go to a smaller village, or a tier 2, tier 3 city, town, you might not have all the facilities there. So that is a gap that we need to bridge. The public and private sector need to work together and make sure we bridge that treatment gap. But we also need to address the financial burden issue. And as you know, of course, we have the Ayushman Bharat scheme, which is currently catering to the bottom, part of the pyramid in terms of the population, the poorest families. But we need to constantly see how we can improve this insurance scheme. How can we include the latest cancer treatments, in the insurance coverage package? And how can we really make it accessible for people across the country? And I think I keep stressing on that, because when we're talking of cancer care, we're not just talking of Delhi, Mumbai, or a metropolitan city. We're talking of our rural and remote and tribal areas as well. And I think from a government policy perspective, that is what I think we really, really need to focus on, because that is where we see the biggest, care gap, as well as financial burden. So yeah, these are some of the areas that we're focusing on from the policy side.
Great. Thank you very much, Ms. Urvashi. Dr. Prakash, my next question is for you. What is the role of caregiver in the journey of a cancer patient?
Yeah. Thank you, Dr. Neha, actually, for bringing into limelight the role of caregivers, because I think if we are to close the care gap, we do need to address the caregiver stress and strain that they go through. And I think caregivers are extremely important in the care journey, because nobody is prepared to be a caregiver. And as they become a caregiver, they have to take on so many more roles. They suddenly become, for example, a medical advocate in a sense of having to navigate, understand so much more about the disease, fix appointments, understand the healthcare system. They become nurses in a sense that they are caring for their patients at home in terms of how you lift them, how you kind of need to feed them, their diets. You become a counselor supporting them emotionally. You have to manage the household while you're caregiving and perhaps even earning a wage. And so all these roles do create a lot of stress and strain, and they need to be addressed. And often it's neglected because the attention is on the patient. I think in our Cipla Palliative Care Training Center, when we started it, we started a family care model. So the patient and the caregiver come into the center and are there here together. And we found for many caregivers, it was the first time they had a night's rest without having to worry because they had people to take care. And so it's respite often that caregivers require. It's also about empowering them and training them to be able to care for their patients better. And I think while we care for caregivers, they really influence the treatment as well. And so it's really important to address their needs because often at times they don't want their patient to know certain things about the disease. There's collusion. Sometimes there's denial about what's going to happen. And they have to deal with uncertainty. Therefore, I think it's the multidisciplinary approach where sometimes the counselors, the social workers, looking at the financial burdens are so important in this cancer journey to be able to support them. And that leads actually to better adherence to treatment at times. If the caregiver can be supported, they are able to support the patient better. And the patient is able to adhere to treatment because they're prepared for what's going to happen better. So extremely important. I think more attention really needs to be paid to the caregiver.
Thank you, Dr. Prakash. I'll move on to Dr. Harit now. Dr. Harit, you spoke about the female cancers. Now, can you throw some light on the common male cancers in India?
Sure, yeah. So I think the male cancers, there's some pattern which I can say in a general way. For example, lung cancer is the number one cancer and one of the most common cancers among the male population. But for example, oral cancer and head and neck cancers, squamous cell carcinomas, these are common in northern India. However, in the coastal area in the southern, around Chennai and Kerala, gastric cancer is the number one cancer amongst male in that population. The common cancer, obviously, after lung, head and neck is very common. And then we come to GI cancers. Colorectal cancer is not that common in some parts of the country, but in Bangalore, for example, it's on the rise. So there are certain patterns related to dietary and lifestyle issues. And there we see a variation. Having said that, I think we can focus safely on lung, oral cancer and head and neck cancers and GI cancers.
Thank you, Dr. Harit. My next question is for Dr. Jyoti. Dr. Jyoti, what are the major risk factors associated with cancer?
Mute, I think.
You're on mute.
Yeah.
Right. So I was saying a very relevant question, and many times there are several myths also which are prevalent regarding the risk associated with cancers. So first, I would like to also mention that whenever we talk about a risk factor, it means that if this particular factor is associated, the chances of getting cancer is increased, but it is never absolute, like 100%. At times, some patients are really worried that I am having certain risk factor, patients and their relatives rather, that I'm having so and so risk factor, so I will 100% develop. So it is never 100% or it is never 0%. It is always fall in between. If some people are associated with a risk factor, their chances of getting cancer becomes higher. So some of the known factors are, smoking, alcohol, which are associated with several types of cancers. There are, certain other chemicals like asbestos, dye industry exposure, or several other pollutants. Then obesity, stress in some amount. So these are the factors which can be to a certain extent modifiable also lifestyle, the dietary factors. These all factors are associated, and if there are more than one factors, then at times they become synergistic also. So these are modified factors, so something can be done about that to reduce stress, to reduce the consumption of alcohol, smoking, to decrease stress levels, also to induce exercise in your daily routines. So all these factors are important. Some factors are non-modifiable. So a small chunk of the cancers, as Dr. Chaturvedi also mentioned in the past, that 5% or less of the cancers, they are hereditary in nature. So they run in families. So if a certain kind of mutation is present, then the chances of getting a similar kind of cancer or a group of cancers becomes higher. I always quote Angelina Jolie for in this regard, because I have very high regards for her, that because she is one person who has increased the awareness for hereditary cancer exponentially, and no amount of big programs could do that, and people become very very aware. Once she was diagnosed, she was having a BRCA mutation gene, and her mother and grandmother, they both were affected, and they had poor outcomes due to that. So she has taken a step to prevent, and she underwent prophylactic bilateral mastectomy because of that reason, to prevent the risk. So in very small percentage, this kind of mutation can also run in the family, which is a risk factor. And if these are present, then there are facilities for proper genetic counseling, addressing those risks and minimizing those risks by appropriate measures, as one of the measures taken by her as well. Thank you.
Thank you, Dr. Jyoti. Dr. Niti, we have been hearing a lot about genetic counseling. Could you throw some light on the role of genetic testing and counseling for cancer patients?
Neha, this obviously, as you said, is a very emerging and a very hot topic of discussion. I would like to take this question in two parts. I mean, I think Dr. Jyoti and Dr. Harit Chaturvedi also very classically illustrated. There is a lot of gap between what we understand as genetics of cancer. So, when we are doing a molecular profiling or we are doing genomic profiling of cancer, it could be the tissue you are analyzing to look for certain genetic subtype of tumor. So they may express one type of mutation versus the other type of mutation, and certain type of cancers are actually totally reclassified based on the molecular classification. For example, lung. Now, lung is a spectrum of cancer. Even adenocarcinoma of a lung is a spectrum of cancers. It could be EGFR positive, it could be ALK positive, ROS, MET, RET, KRAS, BRAF positive, and a whole spectrum of treatment is directed to these mutations. So there's a problem and there's a solution. So there's a targeted solution to a targeted problem. So this is a molecular classification based on genetic markers of a tumor, which is analyzed mostly on tumor tissue, but it can also be analyzed on blood. But what other subset is that 5 to 10% hereditary cancer, in which you actually send your blood sample if you have your first degree relatives, or there are certain unusual type of cancers in you, like Dr. Harit said, a male breast cancer or bilateral breast cancer, or there is a spectrum of cancer in your family, like prostate, pancreatic breast cancer, or a single woman has breast and ovarian cancer both. So there is a small propensity for them to have hereditary cancer. In this, you can identify a heritable mutation which can be transmitted in your family. So it could be in your brother, sister, so it could be in your mother or father, or it could be in your child. So there we normally do a saliva swab or a blood test to identify this gene. And then when you have a gene which is positive, there could be a treatment for that as well, or there could be some implications on your family to test them so that they can find out their risk and cut their risk. Now, the next question was genetic counseling. Well, when you're doing these type of testing, especially when you're doing testing for hereditary cancers, we normally give a pre-test counseling and a post-test counseling. So we have to make the patient understand, or make the person understand, what are the implications if we get one type of result or the other. Some people may actually opt out of doing a test. You may actually have a very strong family history, and you have been told by a genetic counselor or your oncologist that this is the pros and cons of doing a test. And some people may actually be very motivated to do it, but you also have to tell them the downsides of these tests, because certain type of mutations you may find, but you don't have really a solution for it. And it adds to mental agony as well. So those points also have to be addressed while doing such tests.
Thanks, Dr. Niti. I have another question for you. Is there any role of nutrition during the management of adult cancer and management of pediatric cancer?
Yes, onco nutrition is an entirely different subspecialty. And nutrition plays a very important role. First, we have to understand that cancer itself can be a source of cancer related weakness or cancer related cachexia. All advanced malignancy, a person is undernourished and having weight loss. Sometimes people present with weight loss and they are diagnosed with cancer. They get a head and neck cancer, a person has obstructive lesion, can't even eat. Stomach cancer may itself cause a lot of poor nutrition and weight loss. So first is what is the type of cancer, and therefore you can titrate the diet accordingly. But in general, when the patient is on cancer treatment, which could be chemotherapy, done surgery or radiation, we will give tumor specific recommendation, but there are certain general recommendations, and those include small frequent meals, that every few hours somebody should be taking food which is probably a short and quick source of energy. It could be rich in carbohydrates, but cancer patients also have a lot of protein loss, so you have to supplement it with protein. Almost 1.5 gram per kg body weight is the extra supplemental proteins that is required for all patients. All patients should take diet which is rich in fruits and vegetables. Oil or fat should be cut off, because anyway there are so many medications going on, plus your digestion is poor. And red meat is one recommendation which normally is told to avoid whenever feasible. Then certain specific diets, like if you have neutropenia, counts are low because of treatment, then there is certain specific neutropenic diet which is suggested.
All right. Thank you, Dr. Niti. My next question is to Dr. Boman. Dr. Boman, with the advances in management, what are your thoughts on survival of cancer patients in early and advanced stages?
Yeah, it's a good question. In early, so of course, we know we are curing most of the patients. Like in solid tumors, surgery followed by chemotherapy, early stage cancers, we see cures. Very rarely we see long-term side effects in those cancer survivors. And those long-term side effects are sometimes related to cardiac problems, some have vascular events. So those are very cholesterol and the dyslipidemias. So those are the things that we may see in early cancers, those who are cured with our standard treatment like chemotherapy or surgery. Surgery may have some disfigurements, but or some that may be external or sometimes internal. As somebody said, that small frequent meals if your stomach has been removed. So those are some things which we see in early stage cancer. Now in advanced cancers, with the recent advances which have occurred, as Dr. Niti has told you, there are so many things. In lung cancer, for example, few years back we did not have any treatment, and we used to say, oh, just chemotherapy. And above 65 years, we would say no chemotherapy, and we would many times send the patient home. But with these advances that we have, not only in lung cancer, but in melanoma and many other diseases, when immune checkpoint inhibitors have come, targeted therapies have come, we have made these many of these diseases now in a chronic disease, like how diabetes, go on taking tablets or go on taking some injections like immune checkpoint inhibitors, and the life goes on, and they have really a reasonably good quality of life, even when they have a very advanced disease, if they have those specific targets or if they have some favorable factors for immunotherapy. So life has evolved, the change, the cancer treatment has evolved a lot since last 20 years, what I could see in my whole career.
Thank you, doctor. Thank you very much. As Ms. Urvashi highlighted that many patients are still devoid of standard care in cancer treatment, mainly because of financial constraints. Ms. Urvashi, is there any development on healthcare for cancer, and are there any existing schemes to make cancer care more accessible for these individuals?
Yeah. So sorry, could you repeat the first part of your question?
My question is there any development on healthcare for cancer, and are there any existing schemes to make cancer care more accessible for individuals who are not able to avail the standard care because of financial constraints?
Yeah. So, of course, you have the standard, public health system, which is, anyway existent at all levels of the health system, right? From primary care through to secondary and, tertiary. You have the district hospital. So you anyway have that network, which is, supposed to provide, cancer care, and, a lot of it is either free of cost or it's highly subsidized. The challenge we face there is the quality of the services that we're able to provide. And there is a big gap in terms of quality in many parts of the country. Again, when I speak of India, I really cannot speak of it as one from a policy perspective. India is so many countries, and every state is so different. But in general, quality of services that we are providing is a challenge. And also people's perception. A lot of times people actually perceive, that we will get a better quality, in a private facility, even though we are paying a much higher price. But we'll actually get better quality than we'll get, in a public facility, which might be free of cost or which might be highly subsidized. So we have both those challenges to address as far as the public system is concerned, in terms of actual quality of care, and where the care is delivered. Like I said, if you have to travel long distances to access care, then it's not truly, access in the right sense of the word, right? If I have to travel from Jharkhand, poor tribal area, to Delhi for treatment, then that's not really access, because it should be close to, where I'm living. So that is one, part of it that we're trying to address. We're working with various state governments on that. As I said, there's no, one size fits all policy or approach you can have for this. You have to work with individual states. But the other part is actually also changing perception of people that, the care will not be good, if I go to a public facility, and so both the actual quality as well as perception are to be addressed in terms of issues. And then, of course, the engagement with the private sector, because the private healthcare also, in India, it's very diverse, it's very varied. Not all of it is organized, not all of it is high quality. So that engagement is also very important, because we need to bring in private providers as well into the ambit in order to be able to provide access to care in all parts of the country. I was mentioning the tier 2 and tier 3 cities and towns. So through Ayushman Bharat, we are looking not just at strengthening the public health system, when it comes to treating conditions like cancer, but also how do we expand the network of private providers, into these areas. How do we incentivize them? Because you don't need an incentive to necessarily set up in a Delhi or a Bombay, but you might need an incentive to, go to a tier 2 or a tier 3 city or town. So that is something that we're also focused on. And the second part, which I was touching upon earlier, is the actual insurance coverage. Because while we do have a certain package today covered under Ayushman Bharat, and we cover the bottom part of the population, the poor families, we do constantly need to look at how do we expand the package of coverage. So how do we cover, say, a latest advancement in cancer or a new treatment? How do we actually provide coverage for all of that? And also we have to expand insurance eventually to what we call the missing middle. Because in India, you don't have just poor families, but you also have, families which might not be poor, and yet they cannot afford health insurance, So that's what we call the missing middle. And we need to, provide them financial protection as well, against something like cancer, which can really be a catastrophic, expenditure, depending on what type of cancer and how much you have to spend on treatment. So I think those are, all avenues that we're trying to address, partly through Ayushman Bharat, partly working through different state government schemes. But that's very much a policy focus right now.
Thank you, Ms. Urvashi, for the insights. My next question is to Dr. Harit. Doctor, what are the recent advances in breast cancer surgery? And can every woman go for breast conservation surgery?
So thank you, Neha, for asking that, because I think it's very important to highlight that today organ or disfigurement is not part of cancer treatment. The thinking that radical surgery actually means mutilating surgery is gone beyond past. We have gone much past that. Whether it is breast cancer, head and neck cancer, or limb sarcomas, the function and the organ, as much as possible, has to be preserved and to be restored to the original form as much as possible. So as far as breast cancer is concerned, today, early breast cancer, I can safely say that most of the patients are suitable for conservation and opt for conservation. In our practice, almost 60% of patients opt for conservation because we get a good chunk of early breast cancer. However, if it is a multicentric disease and not suitable, even though early, there's a different situation. Not just in early, even in locally advanced breast cancer at times, by starting with chemotherapy first or systemic treatment first, we are able to downsize the tumor, and then we can offer conservation in these subset of patients as well. Having said that, I want to emphasize that it should be duly and properly planned, because if the initial imaging, initial assessment and planning and the surgeon is not part of the before starting chemotherapy or systemic treatment, at times we are at a loss. We do not know where the tumor was and how to offer conservation. So it's basically a teamwork where the team has to work together to deliver the very first best treatment. And it's not just about the breast, even about the axilla, for example. Earlier, we used to do an axial lymph node dissection, which had almost 25-30% incidence of lymphedema, the swelling in the arm, which used to be significantly morbid. Now we are able to exclude almost 60-70% of our patients from full axillary dissection. We are doing sentinel node biopsy. For this, it is important that the pre-surgical planning of axilla has to be very thorough. It has to be assessed not just by clinical examination, but by ultrasound and imaging also, to make sure that we're not missing any node, having targeted every node. Now, looking at that in a LABC also, locally advanced breast cancer also, after chemotherapy, we are in a situation to offer sentinel node biopsy. So, and I would emphasize the role of oncoplasty. Oncoplasty is a technique where the plastic surgery principles are being applied by oncologists to ensure that we are able to deliver what is required by oncological safety, that is clear margins, the volume of tissue loss. At the same time, are able to mobilize the breast tissue for appropriate shape and form. For that, we need to look at the volume loss, how we are replacing that volume, how is the centering of nipple done, and various components of that. So that is part of the plan. So oncoplasty, sentinel node, good imaging, good surgical planning is we are able to offer breast conservation. I would put in a general way, almost 80-85% of patients qualify for it. Though those who opt for it is somewhere around 60% in our practice. This can vary very much from center to center.
Okay. Thank you. Thank you so much, Doctor. Dr. Jyoti, my next question is to you. What's the relationship between cancer therapy and fertility?
So thank you, Neha, again. Because these days cure is one of the very important criteria, but quality of life is also equally important. With the advancement in care, we are able to achieve cure in large number of patients, especially if they present to us early, well in time, and can be plan their treatment appropriately. Then our entire goal becomes that we are not only treating a tumor per se, but we are treating a patient as a whole. So we want them not only to get cured, but we also want them to go back to their normal lives as much as possible. And fertility is an essential domain. So I'm especially inclined to this particular thing. You can say it's really close to my heart. So cancer drugs, especially the chemotherapies, etc., they can lead to infertility in large number of cases, and depending upon what kind of regimen, whether you are using multi-drug therapy or single drug therapy, or what kind of dosages you are using, and what class of drugs. For example, we call it 𝗜𝗏𝗘𝗥, one kind of group of drug which is very, very commonly used and in breast cancer and in several other cancers as well. So these are having higher propensity to cause infertility. So upfront, what we do, we counsel our patients and those who are in reproductive age group, or even when they are pubertal age, or at now even pre-pubertal, because we have to predict that what is their chances of infertility in their later lives, especially when the cure rates become so high. I treat sarcomas, so in bone sarcomas, the predominant age is around 17 years, peak years. So these are the at this vulnerable age, they are very prone to so now the cure has become very high, and their chances of later on infertility is quite high. So we counsel these patients, we send them from sperm preservation. So in male, the sperm preservation is a pretty simple procedure. It is pretty, cheaper as well, and it's widely available. For example, if I say, because I'm in Tata Memorial, so next to Wadia Hospital, which is again a government setup, and we're in with very economic rates, we can provide them sperm preservation, and later on the very high success rate. So this we are doing as a routine. And we also have dedicated adolescent and young adult clinic, wherein we can counsel them at length. Also, there are several NGOs, etc., there who can provide us with different kind of aids and support. When it comes to female, the procedures are a bit more complex. The availability is also not as common as for sperm preservation, and also expertise is needed, and also the time taken for this procedures are a bit long. So we have to be very judicious. And when we are doing what scenario, for example, if I'll say that when we are, so in female, the infertility is related with age. What age you are giving the chemotherapy, what is the ovarian reserve present in these girls or women. This all is very important, and of course the dose and cycles of chemotherapy. So for if we are giving a very young age, for example the 17, 18, or even less than 30 years, then chances of their recovery of menstrual function and fertility is very high. Vis-a-vis if we are giving at the borderline age of around more than 30, 35, then their chances of developing a premature menopause is very high and later become infertile. So breast cancer, that's why, because that happens at the age of it's the hormone receptor positive disease at a very it's a late age disease, but triple negative and HER2, which is at a younger age also. Then also they are predominantly they are more than 30 years or 35 years. So these women, we have to be very, very carefully counseling, sending them for fertility specialist, and in time doing procedures like embryo cryopreservation or oocyte cryopreservation, which is having a fair amount of success rate, more than 50% in good centers. So this should be carefully counseled to the patients, and meticulously done as a multidisciplinary teamwork, where fertility specialist also becomes an important part. So many times, what happened when we tell them about the diagnosis of a cancer, they becomes very disturbed naturally, and that time they are not receptive to understand all these things. So perhaps it is not the best time in the first counseling, but it should be a staged manner. In second time or third time, when you are seeing a patient and planning the proper treatment, that time these aspects must be discussed and very sensitively dealt with, because later on when they become long-term survivors, these all questions come up, and that time if this is not being taken care appropriately, then this is having a very bad effect on quality of life. Because we are discussing quality of life, and just before that Dr. Chaturvedi discussed about the breast conservation, etc., I would also like to add upon one line that not only we can conserve breast, and not only we can preserve their fertility, but also we can preserve their cosmetic appearance in other manner. For example, there was a dreaded side effect with chemotherapy, the alopecia or the hair loss. So becoming bald, it's a major stigma in every kind of societies, whether it is a urban society or it's a rural society. There are different kind of complications, and when you closely talk to the patient, they said it is even more catastrophic than losing a breast, because it constantly reminding them of getting a cancer and their societal acceptance. So we have done a randomized trial with scalp cooling to prevent alopecia. It was very successful. So world over this is happening, and now we are pioneer in Tata Memorial Hospital. We did this trial successfully, and we have had this scalp cooling machines now, and now it is in many parts of the country as well. So not only the woman can be cured, they can preserve their breast, they can preserve their hairs and fertility, and live a very dignified life.
Thank you, Dr. Jyoti. My next question is to Dr. Boman. Doctor, do cancer patients really need palliative care?
Of course, that's one of the very important part of the whole treatment. It's not that the palliative care starts only when the active treatment stops. That's a misconception. Palliative care should start from the day one for any chronic disease. Cancer is believed like a chronic disease. So palliative care is also good for non-cancerous disease where it's a very chronic journey. It's a whole journey which should be supported, and not only for the cancer patient but for the caregiver also. This whole journey, how to make it smooth, is a job of a palliative care specialist. This can be in the form of counseling, psychologically, getting even appointments, sticking to time, sticking to treatment. Now, all these things come as a part of palliative care. So palliative care doesn't mean that just giving the treatment when the cancer treatment is stopped and just go on doing painkillers. So palliative care is an integral part of cancer treatment, and I feel wherever there's a large oncology center, they should have a palliative care department. Unfortunately, I don't see that in India in many places.
Thanks, Doctor. Dr. Prakash, what are your thoughts on palliative care in management of cancer?
Yeah, I'd like to echo what Dr. Boman said really is that, palliative care is not end of life care. Palliative care has to start from the beginning. And, that's a perception really that we need to change. And as Dr. Jyoti has said, things about hair loss, body image, these fertility, these need to be discussed early on. And so we have to realize, therefore, palliative care is really being from day one, and especially in India, when a lot of cancer is diagnosed towards the end. People do really need to have talked about these decisions, and it doesn't happen just once. It's a series of conversations that have to happen. And palliative care is unique because it offers that multidisciplinary approach. So it's got a doctor definitely who's looking at pain and the symptoms. You're looking at how the disease is really going to impact on you as an individual, on your family, who's caring for you, and that coordination sometimes is missing. Palliative care is preparing you for what's going to happen ahead. And so it's really important that palliative care is introduced early on. And I think it's best when it's really integrated into care. So it's not really a referral to palliative care, but it's a joint shared working. And if we could have professionals, the palliative care teams who are available in hospitals as a unit, as an OPD, then they can be really called upon early on. And the counselors can be part of those conversations at the beginning so that rapport is built. And so, towards the end, when decisions have to be made, patients and caregivers are already familiar with a team and a resource that they can draw on. And I think it's really important, therefore, that palliative care professionals also really understand about the disease trajectory, that they are better informed, that there's really a close working between palliative care professionals and the treating physician. I think that's really important to have that communication and that joint and shared care. Because really, palliative care can transform the healthcare system by being more person centric. And that's really where we have to use its full potential of working together and really helping and supporting families throughout that journey.
Great. Thank you so much, Dr. Prakash. This brings us to the end of the discussions. Thank you very much to our esteemed panelists for sharing knowledge on different types of cancer and the advances in cancer diagnosis and cancer care. I would leave the audience with a thought rather than a question. This Cancer Day, what will you do to close the gap in cancer care? Please share your thoughts in the comments. Thank you everyone for joining us today. Have a great weekend.
Thank you very much. And